When we look at treatment, we've got a number of different things that we can do. We're going to start looking at different medications. So with the medications here, we're looking at differentiating between high molecular weight heparin and low molecular weight heparin. High molecular weight has been what we have used for years and years and years and years. This is the unfractionated heparin, and it's been the mainstay for an acute PE for a really, really, really long time. With the high molecular weight heparin, we have to get those bleeding or those clotting time values. And the one that we're looking at specifically is that PTT. We're looking at the PTT to see if that patient has too thin of blood or if it's still too thick. So that is what we're looking at. We're looking at identifying those values. When we look at the bleeding, bleeding can happen spontaneously. So that's a complication or a risk when it comes to the high molecular weight heparin. Now, we've started to move into this low molecular weight heparin, and with the low molecular weight heparin, we're seeing that it is recently become more and more available, and we're seeing that this is safer and more effective for DVT prophylaxis or preventing DVTs than the high molecular weight. It is much more cost effective than the high molecular weight heparin, and we do not require the PTT when it comes to the low molecular weight. So this is becoming more normal. This has been the normal for a really, really long time. Now, when we're looking at the low molecular weight heparin, we're talking about using warfarin or Coumadin, either one of those. Those are the same medication, just trade name, brand name. Looking at using warfarin and heparin together. And what we want to do is we want to give those two together for about 5 to 7 days. And we're going to use that timeline as long as the warfarin shows that it can effectively prevent clotting. So we're going to start to wean the low molecular weight heparin and then DC it within those 5 to 7 days. When it comes to like the timeline as to how long you'd be on these blood thinners, it's a kind of a toss-up, because you could have a patient that's simply going in for a surgery and they would be on low molecular weight heparin for 2 to 4 months, or they'd be on Coumadin or warfarin for that period of time. If you have somebody that has prolonged bed rest, then you might look at a more 3 to 6 month timeline for using heparin. And then there's patients that use heparin indefinitely, and because they have reoccurring PEs or other clotting disorders. And when we look at this, some of the medications that don't do well with warfarin are acetaminophen, are ibuprofen, are herbal preparations or dietary supplements. All of these can exacerbate those bleeding times and cause the blood to get too thin. So we would just want to make sure that we're being careful. And we also want to be aware of any high vitamin K not medications, but oral intake or foods. So broccoli and spinach and leafy greens. If you're one that eats liver and onions, that would be an increased source of vitamin K. Grapefruit juice is another example of that increase, and green tea. So when we look at alternatives that we want to use, we could use rivaroxaban, or Eliquis. We could use either one of those to help us out. Now, when we're looking at thrombolytics, we're talking about the suffix either place or ACE, ASE, not ACE, but the ASE medication. So streptokinase, alteplase, activase, reteplase, all of these are medications that are used as a thrombolytic agent. And a thrombolytic, what it does is it lyses, it tears up, it breaks apart. It is a clot buster. Anything that has that lyse in it LYCE, those thrombolytics are medications that are clot busters. Used in conjunction with heparin, there's a risk for bleeding, and we just want to make sure that we do everything that we possibly can to take care of our patients so that they don't have issues when it comes to the specific medications. When it comes to other preventative measures that we can use, what we're talking about is walking, exercising whenever you're in long seated positions, hydration, and compression stockings. So walking, going on frequent walks. So anytime that you're in a long car ride, you want to encourage your patient to stop often and to walk around or to do some air squats just to get the blood circulating in those lower extremities. Typically, we want to see this happen like every hour. Every hour that the patient can stop on a long car ride so that they can walk and move around and do those air squats or those deep knee bends. We want to encourage the patients to do that. So education when it comes to preventative. When we look at the exercise while seated, we want to encourage to flex and extend. So flexion is to pull in, extend is to push out. We want to flex and extend and even rotate the ankles so that we can keep mobility and keep movement in those extremities. We want to press the feet. You can press your feet up against the seat or the chair in front of you, or you can simply raise your toes up and down. All of these are going to create mobility, and that mobility is going to bring more blood to the area, less clotting. So lots of activity when it comes to taking care of these folks. Hydration. You want to make sure that you're drinking plenty of fluids. You yourself, and make sure your patients are taking care of that as well. You want to do everything that you can to avoid dehydration and even avoid alcohol, because alcohol has some properties in it that have diuretics. And if I'm peeing everything out, then I'm not staying hydrated. So when we talk about compression stockings, what we're talking about is wearing tight-fitting elastic stockings. And what these do is they squeeze the legs. And whenever they squeeze the legs, they help the veins and the leg muscles move blood further through. It's a form of Poiseuille's law. If I squeeze through, that'll increase the pressure. If I increase the pressure, I'll keep mobility going in that vasculature. This is a safe, simple, and inexpensive way to keep blood from becoming stagnant. So the stockings are, in combination with the heparin, are much more effective than heparin alone. So this is a conjunctive therapy to the heparin. Now looking over here at the IVC and the IVC filters, this stands for inferior vena cava filter. This is a surgically placed filter that prevents clots from being carried into the pulmonary circulation. This is recommended for high-risk patients only. Some of the complications include edema distal to the filter. So we just want to make sure that we are doing everything to prevent any sort of additional fluid where it's not supposed to be. The thigh-high cuffs, or the pneumatic compressor, this is a compressor that squeezes and it inflates every few minutes to manage and to massage and compress the veins in the legs, significantly decreasing the risk for blood clots from patients with a hip replacement surgery. And the last thing here is a pulmonary embolectomy. Pulmonary embolectomy is a surgical removal of clots from the pulmonary circulation. This is our last resort for treating any pulmonary emboli, and it's because there's an increased risk to the mortality rate when we're talking about taking these procedures on. For us as respiratory therapists, we want to be able to recommend all of those previous interventions and all those previous treatment. But when it comes to what we can do, provide oxygen. if we're starting to have patients that have a pulmonary edema or a flash pulmonary edema, we want to add positive pressure to that because the oxygen alone will not help. So when they become refractory, when they have a PF ratio less than 200, I know that we've talked about that before, but a PF ratio less than 200, then oxygen alone is not going to cut it. We've got to start adding positive pressure ventilation, whether that's CPAP or PEP therapy, whatever it may be, to improve that PF ratio. When we have the patients that have the bronchospasms and they have the wheezing, get your aerosolized medications. Utilize your albuterol to take care of that patient for the signs and the symptoms that they are having. And then last thing we want to do is lung expansion to make sure that we are not having any sort of atelectasis. So lots and lots of treatment when it comes to taking care of patients with a PE. Be sure that you know those medications. Be sure that you know those labs. Be sure that you know what imaging you want to use for diagnostics and different treatment paths or different treatment plans when it comes to taking care of a PE.